get started. This meeting is being recorded. And welcome to Harm Reduction. It's good to see everyone this morning. You can go to the next slide. If you don't mind keeping yourself on mute, unless you'd like to unmute and ask a question or provide a comment, we would appreciate that just to avoid any unnecessary feedback and so we can all hear each other well. And if you're unfamiliar with Zoom,
sure I understand.
The mute and stop video, if you need to go off video at any point in time, if you need to take a break, are at the bottom left hand of your screen. And the chat should be somewhere in the middle. If you want to drop questions and comments in the chat, we'll be monitoring those throughout. And of course, encourage you to respond to each other's thoughts with emojis, or if you like something that we said particularly, those are also, that's towards the bottom right of your screen. We can go to the next slide. The agenda for today, so we'll go through introductions, talk about what we're here to learn, go through some agreements about how we're going to engage as a group. We will talk about the definition of harm reduction and its core principles. We will talk about and have a discussion in a breakout group about implicit bias. And then we'll talk about some practical interventions. So these are things that we'll talk to you about today, and you can bring them right into the field and use them in your daily work when you're working with folks in encampments or on the streets or that are just generally using drugs. We will talk about the role of the helper, so that's all of you, and the dignity of risk, vicarious trauma and self-care, which is important in any setting, but especially when we're talking about harm reduction. And we will have a case example along the way and a discussion about how you might apply these to your work. And then at the end, we will leave some time for some question and answer. Next slide. And today we hope that you walk away learning the principles and benefits of harm reduction as an approach. We hope that it supports you in rethinking how you might work with someone who's actively using substances. We hope that it will increase your self-awareness about any biases, thoughts, and feelings you might currently have about harm reduction and how that might impact your service delivery. And also, like I said, practical interventions and the opportunity to apply some of those practical interventions in a role play. Next slide. A little bit about us. I'm from the Technical Assistance Collaborative. It's a nonprofit organization dedicated to helping our nation's human services, healthcare, homelessness, and affordable housing systems implement policies and practices that empower people to live healthy, independent lives in the communities they choose. Next slide. I'm Teresa Young. I'm a social worker by trade and a senior associate at TAC, and I have about 15 years of experience in the field, including homeless services, outreach, substance use services, and I will let my co-host Jordan introduce herself as well.
Thanks so much. I'm Jordan Gully. I'm also a licensed clinical social worker, just under 20 years of experience in kind of the overlap between behavioral health systems and housing. So lots of experience overseeing street outreach, overseeing crisis systems and behavioral health. And so this topic is near and dear to my heart. And it's nice to meet you all.
And if you'd like, you can drop your name, pronouns, and maybe your role or a little bit about the work that you do in the chat. So you can all kind of get to know where you're coming from in the different experience that you might bring to the work. We can go to the next slide while people are doing that. So while people are doing that, just a few agreements. I hope that this will be interactive. I hope that you'll feel free to ask questions and kind of bring your perspective to things. And given that, I know that harm reduction, depending on the audience, can be kind of a different approach and sometimes even a controversial approach. So just knowing that we're all here to learn, we're all here because we want to better support the people that we're working with. We're hopefully here to maybe challenge any biases that we have about the work. And there are no stupid questions. We might have people here from a range of experiences. We might have people here from a range of years in the field. Some might be brand new, some might be old hat. But we want to hear from everyone. And, you know, we are all bringing ourselves into this room and into the work. So we're going to appreciate each other's perspectives and refrain from judging others, please. Next slide. Okay, to kind of set the stage and why harm reduction is so important, we want to talk about the opioid and overdose epidemic in the country. So as you can see on this slide, unfortunately, we have been seeing overdose deaths increase kind of pretty regularly over the past 20 years. Notably around 2017, 2016, we see kind of a larger increase. And does anyone have any guesses about why that might be the case?
Fentanyl.
You are correct. So unfortunately, fentanyl entered the drug market around that time and created a whole host of new challenges. And now it's the predominant substance in the opioid trade. You almost never see heroin anymore. When you're doing drug testing, if you come across that, it's kind of shocking. So that's kind of where we're at now. And it has also made its way into a lot of other drugs people are using. So it's made its way into amphetamines, it's made its way into pressed pills, it's made its way into really, I mean, anything, unfortunately, anything that you can think of, and which has really caused some unfortunate circumstances. And based on preliminary data, it's looking like we lost something like 109,000 people in the last year. So just in 2022, I should say. So just kind of to get a sense of how devastating this is and why we need to really think about our approaches and what's effective and what's evidence-based to combat what we're seeing today. You can go to the next slide. So there are certainly disparate impacts when we're talking about overdoses and overdose deaths. As we saw on the last slide, overdoses have continued to rise, and African-American, Latino, American Indian, Alaskan Natives, people that have recently been released from incarceration, and people that experience homeless have disproportionate impacts. So they're dying at multiple rates times like the normal population. So as we're going through the slides, talking about this work, thinking about how we can reach the populations that are really being disproportionately impacted by overdose death and all of the lives that we're losing. And, you know, I previously mentioned this, but synthetic drugs have also contributed to this increase, mostly because we're seeing fentanyl in synthetic drug supply. We can go to the next slide. Okay, so what is harm reduction? So when we talk about harm reduction, we think of big harm reduction and little harm reduction. Big harm reduction is the overall movement. So it's not just those practical strategies that we're going to be learning about, but I love this quote. It's harm reduction with a capital H and R. This is the movement, one that shifts resources and power to the people who are most vulnerable to structural violence. So that's really, you know, centering client voices. We often think of the beginning of the harm reduction movement as starting with the HIV epidemic in the 80s. And so, as you can imagine, at that time, you know, people were fearful. There was intense stigma. There was a lot of shame around a diagnosis. And so syringe service programs, and not all of harm reduction, but a lot of that movement kind of started there by saying, you know, we need to support these people and empower them to make choices that promote their wellness, and really kind of centering those folks in the development of services. And, you know, that led to the model that we're seeing today. And so always keeping in the forefront of the mind is, as we practice all these interventions that we're going to talk about today, that it's really about shifting power to the most vulnerable people that we work with. Next slide. Little harm reduction is the person-centered practices and policies that empower people to make decisions about their health and lessen the negative social, psychological, and physical consequences associated with certain behaviors. Most of the time, we're talking about drug use, but there's certainly other things that we apply harm reduction to. So maybe living outside, maybe it's sexual risk behaviors. And again, as we move forward, we'll talk about some practical ways to integrate some of these interventions into your work. Next slide. So I'm going to open it up for a little discussion early on in the presentation. And from your perspective as providers here, why do people use drugs? And you can drop that in the chat. And this is an opinion question. So from your perspective, why do people use drugs? So I'll give a few moments for folks to add their thoughts. I see self-medication. Yep. Escape, coping, or especially when our ability to cope is overwhelmed. I see another self-medication. Yeah, not feel the difficult feelings. I think that's what people mean by escape. Trauma. Yes, we're going to talk about that. Hopelessness, unfortunately, we all see that in our work quite a bit. Peer pressure. Yep. Especially when we're talking about younger folks, right? Thank you for contributing those. We can move to the next slide. So someone touched on this already, but we always want to have trauma in the forefront of our mind when we're talking about really any population that's struggling, but certainly when we're talking about folks that are homeless, and certainly that we're talking about folks that are using drugs. So, we're thinking about, I asked that question because we're thinking about drug use, and really there may be so many things behind that behavior, right? There may be so many reasons that people use drugs. So it's kind of chicken or the egg. So they might have a history of trauma themselves. They might have experienced many different types of injustice, whether that's racial, classism, other forms of oppression, whether they've grown up with violence. I mean, there's so many things that we could think about, right? And at the same time, the experience of using drugs and the experience of living outside, especially if we're talking about that cross section, in itself can be traumatic. At the center of trauma, we know there's a loss of control and a feeling of disempowerment, a feeling I didn't have control over what happened to me. That's a huge reason why we experience an event as traumatic. And a lot of times when we're living outside or we're using drugs, we have people that are making choices for us. We might not have the most control over our circumstances. We might witness or experience an overdose. That can certainly be traumatic. Living outside in and of itself can be traumatic. And then there's the stigma and mistreatment by others that our folks experience, the experience with incarceration and the isms that I mentioned. And again, I'm just scratching the surface, like this picture kind of depicts, scratching the surface of all the reasons and experiences people we work with might have had that lead to their behavior that they're engaging in today. Next slide. Just another slide on trauma. One is about the ACEs study and talking about, say, if some of our folks, had challenges growing up, how those experiences can kind of lead to later struggles in life that lead to a whole host of negative outcomes. Substance use is one of them, and that's primarily what we're talking about today. But it also can be related to other health outcomes like chronic diseases, and even, unfortunately, early death. If we're talking about primarily homeless folks, the life expectancy is far shorter than a person that's housed. And again, going back to that chicken or the egg situation, it's what happened. Did they have a hard childhood, or did they have lots of early traumatic experiences, and then the drug use is a way of coping with that? Or did they become addicted and then experience a lot of trauma? But the most important thing is that we approach our work with a trauma-informed lens. Next slide. And also considering, I saw so many good comments about why people might use drugs in the chat, but there are some other ones that we don't always think of. So one is that, unfortunately, substance use is something that activates the reward pathway in our brain, and it feels good. So I think, especially when we're talking about younger people, you might have the experience of experimenting with substances, which is like a developmentally normal thing to do, and it feels good. And so you repeat the action until maybe, or maybe not. I mean, everyone is different, but when we're talking about harm reduction, we're generally talking about people that are addicted. That repeated behavior ends with an addiction, to the point where the absence of substances is uncomfortable. You might hear people when you're out in the field saying, like, I don't even do drugs to get high anymore. It's not something that makes me feel good anymore. I just do it to avoid being sick. And when they say sick, I want you to think of the worst flu that you've ever had in your entire life. And then like times that by 10. It's extremely uncomfortable. Withdrawal from certain substances, if we're not talking about opioids, can also be deadly. And withdrawal from things like amphetamines can lead to long periods of depression. And that's really hard to manage through. So it's that substances make our brains activated and we feel good, but also the absence of substances after it's gotten to a certain point makes us feel really ill. And for opioids, just thinking, really broadly here, there was a period of time where pharmaceutical companies marketed opioids to doctors as harmless, as non-addictive. And so they were widely prescribed for pain. And so many adults, just trusting the advice of their doctor, became addicted. And then when they pulled certain formulations from the market, the availability of prescription opioids on the market became extremely limited, and a lot of folks shifted over to injection drugs. And kind of as this is happening, right, if you're thinking like, okay, lots of adults in the community are getting opioids for their injury, lots of youth in the community might be in their parents' medicine cabinet. And again, having that developmentally normal experience of experimenting with substances, not thinking it was unsafe, not knowing there was overdose risk, not knowing there was even risk of addiction and withdrawal. We can go to the next slide. I see a comment, some people start using meth to get more done. Yep, absolutely. Absolutely, because they might not have the energy to get, how many competing demands do we all have? Like some people use substances to be more productive, but eventually it goes to a place where that's no longer the case. So harm reduction in and of itself is a trauma-informed approach. So first and foremost, it recognizes other people's humanity as inherent. Okay, so you're using drugs, you're just as worthy to me as your provider as if you weren't, because I see your inherent and human worth. And that is like a key piece to how we approach this work. It's neutral towards the behavior a person is engaging in. So again, using substances, okay, let's talk about it. So refraining from that judgment, and it radically accepts people where they're at. So even if they're doing things that we understand to be risky and perhaps not health promoting, just saying, okay, this is what you're doing. How can we have a conversation to make this a little bit safer for you, or a little bit less risk of injury or negative health outcome, or a little bit less risk of overdose? Harm reduction, a lot of it is about giving information and accurate information to empower people to make their own choices, and really decide whether or not they're ready to change, and decide what interventions they're going to implement in their own lives to reduce their risk of harm, not to sound redundant. And a key tenet is also centering the people that are receiving services. So regularly getting their feedback. Maybe it's something like having a consumer advisory board, but just focusing on making sure that their voice is not just reflected, but the driver of the development of any services and programming that are provided. Next slide. Okay, everyday examples of harm reduction that we don't always think of as harm reduction. Exercise. So we know that exercise, and I love to use this example because we know that exercise is something that prevents disease, it reduces the impacts of disease, it has tons of impacts on our health, our mental health, but a lot of us still find it really difficult to start or be consistent with an exercise program. And I liken that to sometimes substance use, because even though we know stopping substances or cutting down could have positive impacts on our health and mental health, it still can be really challenging to make a change. Seatbelts also. So seatbelts, like harm reduction, aren't intended to stop car crashes. Seatbelts are there, like harm reduction, to reduce the harm if there's an accident, if there's a car accident. Something you're probably doing in your work is getting people basic needs for people living outside, reducing the harm of being outside. Condoms, masks for COVID. It didn't get rid of COVID, but it reduced the spread. It reduced the impact, just like syringe service programs reduce the spread, reduce the impact of some bloodborne diseases. And also, like, if we're talking about drinking, a harm reduction technique is designated driving. You can go to the next slide. So given what we just discussed and kind of thinking outside of the box about what harm reduction is, what are some ways that you are already practicing it? And if you want, you can drop that in the chat.
Okay, now it's on mute.
If there's no thoughts, we can move to the next slide. Oh, Sean has a thought. Fentanyl, test strips, Narcan, yes, all of those things are amazing. And if those are things that you're already doing in your work, that's amazing. Yes. Housing people on an overnight basis is what went into the chat. So maybe someone's mostly sleeping outside. They're getting a temporary respite in reducing the harm that might, especially like if it's extremely cold or extremely hot. Those are good examples. Thank you both. Clean and safe areas. Yep, that reduces disease transmission. When we're talking about encampments, access to clean water and keeping the area more clean really reduces the risk. Taking an emergency. That's a really good one. I like that. That's a good one. Thank you, Roger. So just briefly, we'll talk about the evidence for harm reduction. And this slide is really to talk a little bit about some of the misconceptions that people might have about harm reduction as a practice. And I'm pulling this all from a World Health Organization study where they really surveyed the impacts of primarily syringe service programs. So one, they found that universally harm reduction reduced the risk of HIV and Hep C. So those are the two diseases that are primarily spread by injection or sharing syringes. They found no evidence that it increased substance use. I know there is a misconception that harm reduction somehow allows people to continue using, or it, increases substance use, but they did not find that. It didn't contribute to crime, and that it increased the safe disposal of syringes. And I think really importantly, it increased referrals to care. So there are different facts and figures. It's somewhere between 30 and 40%. I didn't put an exact one because I think there's multiple sources that cite different things, but 30 to 40% more likely to take a referral to either addiction treatment or some type of other health promoting treatment. Next slide. All right, now we're just going to go through the 8 principles, and think of these as like the core tenets of harm reduction that if you're practicing harm reduction, you should be integrating into your practice. Next slide. So it accepts, for better or worse, that illicit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. Next slide. Understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe use to total abstinence, and acknowledges that some ways of using drugs are clearly more safe than others. So thinking about it as a behavior on a continuum, like many things are. Next slide. Establishes quality of individual and community life and well-being as the criteria for successful interventions and policies. So again, putting that person at the center, what's going to make their life, their health better, more worth living, as the center, as a focus. Next slide. Ensures that people who use drugs and those with a history of drug use routinely have do we go forward one? Calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs in communities in which they live in order to assist them in reducing attendant harm. Next slide. Okay. We skipped one, threw me off a little bit. Okay. So this is about making sure that, like we talked about before, clients are at the center of program development and making sure they have a voice in the creation of programs and policies designed to serve them. There's a quote that I love about this from Carl Rogers. It is the client who knows what hurts, what direction to go, what problems are crucial, and what experience have been deeply buried. Next slide. It affirms people who use drugs themselves as the primary agents of reducing the harms of their drug use and seeks to empower people who use drugs to share information. So giving information, hoping they'll pass it along to their community. Next slide. Recognize that the realities of poverty, class, racism, social isolation, trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and capacity for effectively dealing with drug-related harm. And lastly, does not attempt to minimize or ignore the real tragic harm and danger that can be associated with illicit drug use. So the quote that I love related to this is, meet people where they are, but don't leave them there. Next slide. Okay, and just quickly, if you want to, I know we're a little behind on schedule, so if you like to add to the chat, whether or not you fully embrace or fully support harm reduction, whether you have kind of mixed feelings about harm reduction, and what you think gets in the way of you fully being on board now that you've kind of learned about the principles, practices, and kind of the philosophy behind it. And we can move to the next slide while people are dropping that in the chat, and I will pass it over to Jordan.
Thank you. So we are going to spend some time talking about implicit bias, and I'm sure you are all pretty familiar with this, but I think, when talking about harm reduction, we'd be remiss if we didn't talk about it, because it's not only about implicit bias of individuals that, as a staff member, of individuals that we're working with, but also the community has implicit bias around individuals who are experiencing homelessness, around individuals who are using drugs. And so in doing harm reduction and in doing the work, we're sometimes fighting an uphill battle for the external community. And I think about, when I was overseeing an outreach team, I had an outreach worker that was, for lack of a better word, accosted by a community member because they were engaging in needle exchange. And it was some of the misconceptions that Teresa talked about, oh, you're just perpetuating this problem and you're creating, this issue and you're just feeding into the issue. And like, the staff member was totally taken by surprise. But it was fed by implicit bias of the community. And so I think it's always important to talk about this topic when we talk about doing this work in general, but particularly when we talk about doing harm reduction work. And so I really like this culture because there are so many things that go into, or this quote, because there are so many things that go into implicit bias. Implicit biases come from culture. I think of them as a thumbprint of the culture of our minds. Human beings have the ability to learn to associate two things together very quickly. That's innate. We teach ourselves, what we teach ourselves, what we choose to associate is up to us. And so implicit bias is really a bias that's a form of bias that occurs by automatically and unintentionally, but it nevertheless impacts our judgments, our decisions, our behaviors. It's an internal judgment and often internalized stereotypes that we may unknowingly assign to others. And so they are formed in a variety of ways, often shaped by our culture, often shaped by our upbringing, often shaped by our past experiences. And sometimes even policies, procedures, systems can serve to reinforce some of these implicit biases. And so it's important to talk about implicit bias and how it impacts what we bring to the table, how we bring it to the table, and universally known, we all have implicit biases, but it's really our job to examine them and challenge them in order to better support the individuals that we're working with, especially working with this population, because there's so many explicit biases for the individuals that we're working with. And so those are often internalized not only by community, by us, by the individual themselves. And so if you want to go to next slide, we think about kind of when we think about implicit biases, we think about the messaging around who's deserving of assistance and how that message is reinforced by systems of how things are funded. And I just think about so many conversations that I had with community members in DC around things like, yes, this person deserves housing, but I can't even afford to live there. Why are they housed there? Or, you know, they need to work for housing like the rest of us, and kind of all this message that individuals we're working with here on a regular basis and start to internalize that, and it becomes kind of an implicit bias. And so it's kind of that underlying biases and messaging and how those are formulated. So they're common among healthcare professionals and really contribute to healthcare disparities. They're often unconscious, as we've talked about. And so there are other things that kind of come up. So are there things for you all, and feel free to come off mute or drop it in the chat. Are there things for you all that come up when you think about how biases may be impacting your work or maybe creating barriers to fully embracing harm reduction? And that may be biases that you hold or biases that individuals in the community hold that are impacting your ability to engage in harm reduction work. So it's a smaller group, so feel free to come off mute if you'd like. Well, I think we're going to spend some time talking about this. So if you want to go to the next slide. We wanted to have a discussion because it's really kind of an important concept and an important part when we talk about harm reduction. So I think we are going to do breakout groups for this, but wanted to talk through what value system guides your work with the individuals, because we all come with different value systems that shape our approach to the work. And how you might see current policies and practices that might be reinforcing explicit biases for yourself or for community members. And then how these biases might be creating unconscious barriers in the current work that you're doing. So I think we're going to spend about 10 minutes just in smaller groups talking through some of the concepts around implicit bias and how it creates barriers for harm reduction.
About avoid overamping. And for folks that don't know, though you may, overamping is technically an overdose on stimulants. So racing heart, overheating, some of those psychotic symptoms that we might see, and in severe cases can cause stroke and death, a different type of overdose, but can be fatal. Over intoxication and injury or illness. We can move to the next slide. So there's some pretty universal advice that applies to almost any substance you might be using. And first and foremost, being around others. Now, when we're saying being around others, I think one important point to make is be around folks that you trust, especially with some of the newer substances in the market. Some of the effects are longer lasting than people are anticipating, and they're reporting like, I blacked out for a full day. I don't remember what I did. I fell asleep in the sun, like things like that. So I think ideally you want to be around people that you trust to take care of if anything happens. But if that, for whatever reason, can't be the case, maybe they don't have established relationships in the encampment or community they're at, being around others so that if an emergency happens, someone can respond. Another pretty universal piece of advice is taking turns when you're using your drugs. Originally, we talked about this more so for opioids, but truly, since fentanyl appears to be in most things, I'm sure you're seeing that, taking turns and having one person use first and the rest of the people around you have Narcan is really practical advice. And something that not everyone always considers. The other is, if you aren't around other people, there are apps and there are hotlines that people can call to have someone check on if they haven't responded in a certain amount of time. Or some of them will get you in touch with a trained responder. And if you're not responding, they'll alert emergency authorities or EMS. And some will ping your emergency contact that you set in the app. So I link those in the resources section if you want to learn more about them, because they really are a good resource for people to keep themselves safe. Especially I find if people have had a period of abstinence and they relapsed, since there's such stigma around that and such shame. As many times as we say use with other people, they might be feeling so ashamed that they're going to use in isolation because they don't want to know that they're ashamed to tell people they're having that experience. So getting the information out there about Never Use Alone or about the various apps that are listed in the resources can really it's a newer and life-saving tool. And if we're talking about, other substances like alcohol, like having a designated driver. So if you're drinking, have a safe person in the group. We can advance to the next slide.
And Teresa, I just want to elevate
Oh, yeah.
In the chat, it just talks about giving Narcan to others being really useful. And I
Yes.
think particularly in encampment situations, I'd often outreach someone who maybe we didn't have a really good relationship with, but they were like, well, I don't use, well, you can use it for your neighbor. And so that just having it, there's been so many times where people just Narcaned their neighbor and were able to save the individual. And so in doing that outreach, often it's, they would say, well, I don't need this. Well, maybe you need it for your neighbor. And then they'd be like, sure, even though, we engaged, we knew they were using, it was just kind of that harm reduction approach of, sure, it's great for your neighbor to have. And so they would have it on site. So.
Yeah, absolutely. Never hurts to have it around. Another pretty universal piece of advice is start low, go slow. So start low, meaning use kind of like the minimum amount, and people will know this, like when we're talking about people being the expert in their own experiences, people know how much they usually use and what's a normal dose for them. So thinking about starting with the lower end of what a normal dose is for you, and going slow means waiting in between doses. So we always say use a test shot when possible. Not everyone is willing to do that. And a test shot would be like a very small amount. This was really prevalent when fentanyl first came on the market and people really didn't know the strength of their drugs. I think everything is fentanyl now. It's still relevant, but it's even more relevant for substances that we wouldn't anticipate to have fentanyl. So if they're injecting stimulants or even if they're smoking stimulants, maybe doing a little bit less, because if you don't have fentanyl test strips, if you don't have an ability to check otherwise, you don't want to take a large amount of it, because if you have no tolerance, that leads to an overdose. So that you can always do more, but you can never do less. And trying to wait time in between doses just to see what impact the substance is going to have on you. So with the presence of things like xylazine, it can have unintended impacts, or just the fact that a lot of the substances on the market now have a lot of different stuff in them, a lot of adulterants that we didn't see in the market before. So we may not expect the effect of the drug. It's going to be different potentially from what we initially thought we were getting. So if you can wait in between, it's helpful. An example of this for alcohol use, because like I said, I like to, hammer home that harm reduction can really be applied to anything. And we always think of it about certain substances, but not all substances. But an example for alcohol is like waiting in between drinks to make sure that you don't get over intoxicated where you might get injured. And we see a lot of drinking in encampments too. So I had a person that he noticed that he had a lot of unfortunate interactions with law enforcement when he drank hard alcohol and drank it very quickly. So he switched to drinking something with like a lower alcohol percentage. I think it was beer, like Coors Light or something like that. And he noticed that he was able to, he wasn't ready to stop drinking, but he was able to avoid feeling like he was in withdrawal and reach a more reasonable level of intoxication that didn't have these unintended consequences in life by just making a small switch. And very important to think about this specific piece of information if you've had a period of abstinence, and knowing that something as short as like 3 days can totally tank your tolerance to the point where like you basically don't have any. So if you even went into treatment for 3 days, you come back out, you're going to use again, knowing that it's probably smart to use less than you did before you went into treatment, because your tolerance can change rapidly. So that, like I said, periods of abstinence, if someone relapses, periods of treatment, and especially periods of incarceration, right? Because when we talked about those disparate impacts, it's something like folks are like 130 times more likely to overdose, not pass away from an overdose after incarceration, but something like 30% more likely to have a fatality after a period of incarceration. We can go to the next slide. Carry Narcan. I think everyone has multiple times mentioned the importance of Narcan. And just a few things you may already know. Most local health departments and health centers, I'm not sure about the exact details from California, have programs through which you can get trained to administer Narcan for free. And often if you take that training, they can give you doses of Narcan for free. It's also available over the counter now. I think the last I saw, Walgreens and CVS had it for like $44, which is pricey. I hope that price comes down, but having it over the counter is a huge step in the right direction. Knowing that, I could do a whole training on overdose prevention, but knowing that if you administer Narcan and a person is not overdosing from an opiate, you're not going to hurt them. And then I always have to make sure everyone knows the importance of rescue breathing. I couldn't do a training and not give that, because I think during COVID and with the new CPR guidelines, people are pretty confused. And some folks have questioned whether or not you need to rescue breathe. And you can actually keep someone alive rescue breathing, even if you don't have Narcan. So if you continuously rescue breathe until emergency responders arrive, you could have saved that person's life. So I think, I always carry a CPR face shield. It's something that if I'm carrying Narcan, I'm going to carry that too, because they go in hand when it comes to that response. Next slide. Test your drugs. I linked a resource in the last slide, the resources slide of this presentation, for DanceSafe. And it's a place where you can actually order fentanyl test strips. And in several states, I know my state, Massachusetts, I can get them for free through the health department. And that might not always be the case in every state. Another place that you might be able to guide folks is to their local syringe exchange or harm reduction program. And I did link kind of like a syringe exchange finder tool in the resources. I believe these slides will go out so that folks will have that so they can guide the people that they're working with. So fentanyl test strips, even more relevant again for things where you don't think there's going to be fentanyl, because we're just seeing it show up everywhere and people are unexpectedly taking it. So all it takes is just a tiny little bit of the substance that you're using and some water, and you can test for the presence of fentanyl. There's also xylazine test strips. I put an asterisk next to that one because there haven't been long studies or multiple studies about xylazine test strips and their efficacy. There have been initial studies that certainly say that they're doing what they say they're doing. But I just, put that asterisk there just so you know.
Okay.
And then another example of this, again, with alcohol is there's products to test whether or not there's something in your drink that you didn't want there. So we can move to the next slide, but testing, especially for folks that are not used to using fentanyl or that's not their substance of choice, is a really available and life-saving harm reduction intervention. Using new or sterile equipment. So folks might not be able to use new equipment every time, but that is kind of like the best guidance. It reduces the risk of infection and a lot of risk of communicable diseases. So like I said, ideally is new, but if you're not able to use new, the guidance is water, 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 bleach, 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 water, water, water. And that means you're pushing a syringe of water through 3 times, a syringe of bleach through 3 times, and then a syringe of water through 3 times. And it's not as good as using a new syringe, but it is something that reduces the likelihood that you might transmit substances or other bloodborne illnesses, not substances, diseases or bloodborne illnesses. And if we're not talking about injecting drugs, we're talking about smoking drugs. A lot of syringe service programs have mouthpieces where you can just change the mouthpiece out. So you're not passing that around. If you have wounds or cracks on your lips, you can transmit Hep C that way. So either having your own mouthpiece that you sterilize and reuse, or people using new ones is considered best practice. And similarly, not sharing things that you are snorting drugs with, if that's the route of administration you choose, because there are those mucous membranes in your nose where you can unfortunately transmit certain illnesses. Next slide. Routes, methods, and sites of administration. So every route of administration, and when I say that, I mean injection versus smoking versus snorting versus swallowing substances, is going to have different impacts. So when you're injecting, you're going to get that rush a lot faster, but it's going to last for a shorter period of time. When you're like swallowing something, it has to go through your stomach lining. It takes a lot longer to get to your into your bloodstream, but it also it might last longer, or you might go for longer without kind of experiencing withdrawal because it has like a slower route of absorption. So some people are pretty tied to the route of administration that they use, but some people are willing to do things like take a break from injecting and try smoking for a little while because maybe they have some abscesses or wounds on their veins, or it's been a lot harder to inject lately. Or maybe they're really just kind of looking to cut back a little bit, and smoking allows like for a little bit more specific dosing or what have you. But talking to people about the different ways that they can use drugs and letting them make an informed choice can avoid, some of the harms associated with substance use. Always taking care of an injection site before and after. So a lot of folks will use bacitracin, but really the most important thing is using like a sanitizing wipe to make sure that you're kind of cleaning the site, because if you use things that don't have those ingredients in them, you're kind of just pushing dirt around. You might actually push the dirt into the site of injection and then set yourself up for more potential for an abscess rather than less if you're using sterile wipes, which they do generally have. I mean, they have them everywhere, but for free often at syringe service programs. Trying not to mix substances. Some people prefer to mix substances, so I think we have to acknowledge that that is a reality and that's something that people do. But if it is an option, not mixing them is ideal because substances impact each other and they can increase risk for overdose. For example, adding a benzodiazepine on top of your opiates, both suppress your respiratory system, making the negative outcome all more likely. And then again, sometimes it's unavoidable because you don't always know what's in our substances, but it does increase an overdose risk. And then in general, if we're talking solely about injection, there are some areas that are more risky to inject in than others. And just general guidance on that is it's less risky to inject in smaller veins in extremities. And as you move kind of in towards your heart, it becomes more risky. Next slide. Sleep, hydrate, eat, and protect yourself from the elements. What a mistake to make. Anyway, so rest. When we're talking about amphetamines, this is particularly important. So you're using amphetamines, it might keep you up for several days. That it really exacerbates the symptoms that you have. And it can increase those psychotic symptoms, and which lead to a lot of negative consequences for people. Hydrating and eating, I think universally, that's just promoting our health, and that's part of harm reduction, right? I won't get into all the reasons that that's important, but it certainly reduces the risk of a lot of illness and injury that people might experience with kind of sustained substance use. Next slide. We already kind of went over this, so I'll skip it, but just a reminder that xylazine is present and it can leave people intoxicated for longer than they intended, which has, promoted unfortunate things like assault, like falling asleep in the sun, getting some severe injury that way, cold exposure. It also tends to cause more abscesses and injuries. And this is just a quick note, if you don't feel comfortable with this material quite yet, there's tons of places, and I've linked some of them in the resources page, where you can get printouts of that just to hand out to people so that they still can have the information. You can still empower them to make choices while you're getting comfortable with this kind of framework. Next slide. And then last kind of framework for harm reduction that I wanted to talk about is good, better, best. And what I mean by this is when we work with folks, we can give them the very, very best practice that we know, like the best way to do something to avoid injury, but we don't want to ignore the reality of what people are actually doing. And people are engaging in a range of different techniques and range of different ways of using substances. And we want to not judge and embrace all of them and talk about at kind of like each different level, like what's one thing that you could do to make it a little bit safer or avoid that injury. And it also gives the full range of information, right? So if we're only giving the best practice, we're only giving some of the information, and then people can't make the safest choice that they're willing to do, right? So we might say, do a tester shot or don't mix your drugs. And they would say, no, like I mix my drugs every time. So what do we do to give them all of the information? Okay, you're going to mix your drugs. So like, what other things can I tell you that can still make this experience safer? So it's making sure that they have a range of options. So then that empowers them to make the choice about what they're going to do to protect themselves. We can go to the next slide. So here's an example, and I'll run through two. So we talked earlier about never using alone. And so we know that the best practice would be to use with someone you trust, to take turns, and everyone has Narcan. But like we talked about, someone, maybe they just relapsed and they don't want people to know that they relapsed because shame and stigma are still, they're way too real. I wish it wasn't that way, but it is. And so they want people to still think that they're doing well, and they're not ready to say like, I'm struggling again. And so they are going to use in isolation. So a better option than just using in isolation would be doing things like using the app that we discussed, that's in the resource page. Making sure your doors are unlocked. So if you do overdose, that someone can get to you. If, someone else in the house is like, hey, I haven't seen so-and-so in a minute. And if your door's locked, it's going to be harder for them to get to you. It's going to be harder for emergency responders to get to you. Let anyone know. And that can be through like the Never Use Alone hotline. It doesn't have to be someone close to them if they're uncomfortable. And again, using maybe a lower dose than you normally would if you were with people, just so that it reduces your risk of overdosing. Good would be if you have to, use alone, and you're going to be like, it's better to be in a public place than to be completely isolated, right? So if you're someone that lives in an encampment and you're going to use by yourself, it's, weird to say, but it's better to use in a public restroom. In terms of keeping someone alive, it's better to use in a public restroom. And Annie, thank you. Don't lock doors in stalls. Exactly. Because then it's that much harder if someone notices that you're down for them to get to you. You just don't want that barrier when someone's trying to save your life. Have Narcan visible. Obviously, we all know you can't Narcan yourself, but if you have it easily accessible on you, a person from the public could administer it if they're trained. or like whoever responds, it's right there on your person if for them to reverse the overdose. And then we have kind of like the avoid categories, like when possible, try to avoid using in total isolation. And by that, I mean like not using an app, not using a hotline, not being in a public place, being somewhere that absolutely no one can get to you. And then certainly avoid using the same amount that you did prior to a period of abstinence. And that's information that you can give to folks. Next slide. So this example is referring to what people mix their drugs with. And so most drugs that people inject, you have to mix them with something else. So there's a lot of things. So most of the time that's water, right? So in order to draw it into a syringe, it has to be mixed with water. So best practice is new sterile water or saline. You may, if you've been in encampments, seen those kind of like little tubes. Those are pretty universally distributed, and like using a new one every time. Not always an option for people. A better option is bottled water. A good option is tap water or water from the back of the toilet. And I know people actually usually have a strong reaction to me suggesting someone use from the back of a toilet. But if you didn't know, that's clean water. And if you lost water at your home and you didn't have anyone to get to you and get you water, you could drink that water and survive. So it's not ideal because, of course, it's not like sterile, and what we would say is best practice is sterile. But it's the reality of what a lot of folks do, especially in encampments where they don't always have regular access to clean water. It kind of depends on the encampment and what infrastructure is provided, but that's a far better alternative than using like water from a puddle, groundwater, or water from the front of the toilet. So just giving people the information so they can make the best choice that will protect them. So we have another breakout group. It'll be about 10 minutes, and we're going to talk about this case discussion. I'll read it, but also know that your breakout group facilitators will have it in front of them in case you have any questions that you want to refer back to. So Jessica is a 42-year-old cis female who uses opioids and stimulants. She states she is not ready to pursue abstinence, but is concerned that she has overdosed several times over the last 2 weeks and ended up in the emergency room. She also reports that some overdoses were not after fentanyl use, but rather after injecting cocaine. She expresses confusion on how that could happen and worries about continuing to overdose. So the questions are, how would you engage Jessica using the harm reduction framework that we just discussed? What information might you provide? So I guess we'll go to the breakout rooms now, and I will see some of you there.
How would you engage us in harm reduction, and what information might you provide?
Thanks again, everyone, as we're kind of welcoming you back for a great discussion. If you want to, again, I welcome you to summarize in the chat if you would like to, or drop any knowledge bites that you might have learned or things that you felt were particularly impactful. And we can move to the next slide as people are rejoining. And this is where, when Jordan is back in the room, I will pass it off to her to talk about the role of the helper and dignity of risk. So I'll let Jordan take it away.
Oh, sorry. Did we just came back into it. I guess we already debriefed.
I just said if they felt like there was anything that was particularly impactful to drop it in the chat, or anything that they wanted to share, they could come off mute or share it in the chat as well. So we can give people a moment to do that, or, however you want to take it from here.
Sorry, we were very chatty in our group, so we came in a little late.
It's a good thing.
Yeah, so thank you so much for everybody kind of chatting. Give me just a second to find me on my screen. So we wanted to spend a little bit of time talking about your role in the relationship where it relates to harm reduction and kind of dignity of risk. And so when you think about kind of your role as a helper, what do you think about, or rather kind of what got you into this work? So how did you become an outreach worker or, a substance use specialist? So, I'm all about chatting, so feel free to come off mute or drop it in the chat. I'm just curious, and as we start to talk about our role as the helper and the role in harm reduction, I'm just curious what got people into the work, because I think that so much plays a role in our role in helping. Lived experience. Oh, yep. And I think lived experience is a great driver in getting involved, but also in engaging individuals and helping them, move forward in their own recovery. Any other kind of things that drove people to get involved in the work? Same. Great. We have a lot of lived experience in the room. Awesome. So I think when I think about kind of why I first started or why a lot of people get into the work, it's really about kind of helping and that role of supporting individuals and helping. And so I think about myself when I first started in the field and really just wanted to do good work, which is generally why, people get into the field, either lived experience. It sounds like there's a lot of lived experience in the room, which is great. We would definitely love to hear from you guys around some of the work you're doing around harm reduction. But I think, we get into the work because we want to help, right? We want to help. We want to, push things forward, and give back in some sense. Those are really kind of the main reasons that a lot of people get involved in the work. But I think when we think about the role of the helper, when we think about people using, Mary says family member. Yeah. So there's lots of things that motivate people to get involved in the work, but often it's really personal, right? It's really personal to ourselves. It's personal to, and so you're committed, you're invested in this work because it's personal. And so when we think about harm reduction, often it's really hard sometimes because you're so invested and you're so committed to the work. And so we think about supporter, not savior, particularly as a supervisor, when I supervised a lot of new outreach staff, it was just, I want to do everything. I want to do all the things. I really want to help. And so, we're going to spend some time talking about dignity of risk and really kind of setting that line between helper and individual receiving help. And so feel free to give me a thumbs up. Are you all familiar with kind of the concept of dignity of risk and how it relates to harm reduction, but also general outreach? And anybody familiar with the term? We're going to talk about something new today. All right, so next slide. So not me. Awesome. Okay. So we're going to talk a little bit about dignity of risk, which is a concept that somewhat started in working with the aging population. But really dignity of risk, we talk a lot about in harm reduction because it is, dignity of risk is the idea of self-determination and the right to make responsible risks are essential for dignity and self-worth. And so it originally came to concept with working with the aging population, and you think about aging in place and people wanting to make their own choices, and but it kind of has been expanded to a lot of the social work realm. And so you think about, when we think about dignity of risk, we think about responsible risk taking. And so our role really with harm reduction is supporting individuals with responsible risk taking. So we'll spend a little bit of time in the next couple slides also talking about safety and how we define safety. But I think responsible risk taking and safety are so connected that when we work with individuals in the field, we're thinking about dignity of risk. Like it's that line between allowing for self-determination, but also, we're here to support this person and make sure they, live and that they are fully embracing recovery and moving forward in wellness. And so we often think of it as kind of a spectrum of responsible risk taking and the role of the outreach worker or the provider. So the role can range from neglect to coercion, and we see all kinds of things in the system that feel coercive. So when you think of coercion, you think of, you're going to lose your housing if you don't, engage in this home inspection. Or we think about, When it relates to substance use, think about people being in mandated treatment. Often that feels coercive, right? And so sometimes we're working in environments where it is coercive. And so how do we honor someone's dignity of risk and honor their self-determination in maybe an environment that feels coercive? And then the other side of kind of responsible risk taking as it relates to being a helper is neglect. And so you think about maybe, oh, you're an adult, you're going to live with those consequences, hands off, I can't change you, I can't, that kind of nothing I will do will change what you're going to do anyway, so do what you want to do. And that often happens, that kind of neglect role in the helper sometimes happens when we burn out, or when we've been working with someone for a really long time and we've been through the cycle a million times and we just kind of start ourselves to feel a little bit hopeless. And so really, when we're talking about responsible risk taking and we're talking about harm reduction, we're really talking about this gray zone that's in the middle. It's the concept Teresa talked about earlier of meeting people where they are, but not leaving them where they are. So we are not doing that neglectful approach where we're like, you're going to do this, you've done it your whole life, eventually you're just going to overdose and then it'll be done. But we're also not saying like, you need to do this in order, because we know coercion doesn't work. And so when we think about responsible risk taking, when we think about harm reduction, we're really living in that gray zone that's taking these strategies to ensure yes, they're currently using, but we've educated them on options and resources and the harm reduction, and that, if you're coming out of a hospital, you're at an increased risk of overdose. And so making sure you're taking those appropriate precautions. So really living in that responsible risk-taking gray zone. So as a helper, our role is to make sure they have the resources, they have the knowledge, that they're making informed decisions, and that we're not necessarily leaving them where they are, but that we are helping to support and do motivational interviewing and move forward. And I see in the chat someone says it's really hard not to internalize people's choices, specifically with lived experience. 100%. And I think that's why we're going to spend some time not only talking about the helper role, but also talking about kind of self-care practices and how do we take care of ourselves, because it is really hard not to internalize. There's an individual that I worked with for 10 years, and the individual finally eventually passed away of an overdose. And it was really hard for our whole team, because we felt like we kind of moved a little bit to that coercion piece where we're like, we did so much for this person, but that wasn't the mentality. We offered the resources, we worked with them, and I think that loss can really amplify, especially if maybe you have lived experience where you're like, I know how this is going to turn out, I really want them to make better choices. It's hard not to internalize. So next slide. So when we talk about safety and managing risk, who's defining safety? I think this is another important concept that we talk about when we talk about harm reduction. So you have to embrace your grief, or that happens 100%. So when we talk about defining safety, we think about who's defining safety. Is the system defining safety? Are the providers defining safety? So for providers, safety generally means maximizing control over the environment and minimizing risk, right? So from a provider perspective, we think about, is this person a risk to themselves? Are they a risk to someone else? But from the individual receiving services, often they define safety as maximizing control over their own lives, particularly if somebody has experienced trauma. What to Teresa's point around trauma-informed care, often individuals who experience multiple traumas don't feel in control of their own life. They don't feel like they've been the one to make these decisions. And so safety to them is to have the autonomy to make their own decisions. And so when we're managing these risks, we're often balancing autonomy and risk assessment. So we're always doing risk assessment to determine that this person is safe, and we're only using restrictive measures when there's an imminent risk. But sometimes, to Annie's point in the chat, sometimes it's hard not to internalize when somebody is making choices that we feel aren't the best. And so sometimes we move more towards that coercive side because we're like, this is unsafe, they're gonna hurt themselves, they're, you know, and so it's that balance of how do we maintain the person's autonomy, but also make sure that we're supporting a safe environment as possible. And I know we have a little bit of time, so I'm just curious if anybody has any reactions or thoughts to kind of how they are balancing managing safety and risk, particularly as it relates to harm reduction. Because I think this chart is lovely and it sounds so easy, but it's really hard to do in practice, isn't it? Right. And a welcome. If you have any thoughts, feel free to drop them in the chat or come off mute. But I think this is, you know, sometimes at the heart of harm reduction is there's this tension between managing risks and promoting safety, and our own, you know, we've spent some time talking about implicit bias, and sometimes implicit bias is, you know, past systems or values, but sometimes it's pushing our own agenda, right? We have a bias that we're pushing our own agenda on this person, that's impacting the relationship with the person. So welcome any thoughts in the chat, but next slide. So when we think about the role, our role as the helper or in the helping relationship, we really want to examine the role. And so this study is a little bit old, but it's been found over and over again. And really what the study found was that it's really the therapeutic relationship, or it's the relationship that you have with the individual, that influences the outcomes the most. And so this looked at not just therapy, but also kind of all social services, different modalities, and found that the therapeutic outcomes, the most impactful and influential, 60% of the outcomes were influenced by what the individual helper did or didn't do. And what they found was more, what made the biggest impact was really the individual's approach, that they were empathetic, that they were warm, that they were non-judgmental, that they were offering and instilling hope. And so for this particular piece, I think it's important because it's really about how we approach the work and what our perspective is. And, you know, that's why we spent a lot of time talking about internal biases. And I just see in the chat in our group earlier, we talked about administrative requirements, coming to appointments on time, taking advantage of transportation and resources as sometimes difficult requirements for people to meet. We didn't identify it as coercion, but I think requirements like that or our attitudes towards people who miss appointments can sometimes be coercive. 100%. I think that that's really what we're thinking about, is like these restrictive, you know, and the term for dignity of risk, they call it coercion, but you're right. I think it's these restrictions or these expectations that are on people that create challenges for honoring their autonomy.
And just to jump in, that kind of speaks to like, if they're not doing it our way, right? And who knows if their voice was included, and we're talking about, you know, that being central to harm reduction, the inclusion of the people with lived experiences perspective. If they're not doing it our way, then we might have a bias and that says like they're not trying hard enough, or they don't view this as important. But the fact of the matter is, like, things are so tough, or there's so many competing needs that this way doesn't work for them. And so if we're practicing harm reduction truly, we want to hear that, and we want to adjust our approach to better serve folks that are saying this way doesn't work for me, and honoring kind of that voice in how services are delivered. Thank you for bringing that up.
Yeah, no, 100%. And if we go to the next slide, I think there's been just a plethora of research around expectation and outcomes. And so, you know, as a social worker, I think about like my social work 101 classes, where it's really about the relationship and the perspective that are the magic in this process. And it's us showing up, providing empathy, providing unconditional positive regard, and the attitude that we bring into the work that has the largest impact. It's not necessarily what we do or the strategies we use, it's kind of that perspective and impact. And that's just been found time and time again in studies. I think the other thing that's been found pretty significantly, there's over almost 500 studies that have found that really expectations of an influential person have impact on achievement. And so what comes to mind for me is you think about the koi in the koi pond. And so koi grow to the size of the bowl they're in. So if they're in a fish bowl, they're very small. I'm sure we've all seen the little ones. But as soon as you put them in a giant pond, they grow huge. Koi can be, half the size of my body. And so it's really about kind of our perspective and our belief that change is possible. And so our attitudes play a crucial role in impact functioning and outcomes. So we think about stigma, expectation, belief about mental illness, belief about substance use, belief of possibility of recovery. And then some of what's kind of between the line is also that personal experience of burnout. And I think it's so easy working with individuals experiencing homelessness, working with individuals who are using substances. It's so easy to get burnt out because to Karen's point earlier, there's system burdens on us that are, system expectations that create it's very hard. There's system burdens of, we're trying to get individuals connected to housing, connected to resources, and their limited resources. There are individuals who we've been working with for a long time that maybe are continuing to use or relapsing or ending up in and out of the hospital. And it's hard not to feel kind of that ownership for that person. And so we're going to spend a little bit of time talking about burnout and compassion fatigue, because I think it's such an important part of harm reduction, because we're all working with an extremely vulnerable population and working with individuals who we just get vicarious trauma. We carry stories with us. We hear their experiences and walk alongside with the individual. And to Annie's point earlier, it's so hard not to internalize some of this. So next slide. And this is just, I won't spend as much time on this. This is just, again, that our role of kind of self-fulfilling prophecy of hope, that a lot of the role of the provider is kind of keeping hope alive. And so if, keeping hope for that person, I think about an individual I worked with that was just like, I don't have hope for that. And one of our peer support staff was like, I'm going to hope for the both of us. And like, finally at the end, they were, fully in recovery and housed. And I remember her coming back and saying, I'm so glad you hoped for the both of us. And so, that role of instilling hope in really the darkest of times and holding hope that this person can recover and that we know recovery is possible and we've seen it, and kind of walking alongside with that person. So next slide. So just curious about kind of you all's self-care practices and how you keep your burnout in check. I'm curious if anybody has kind of self-care plans, or how are you kind of supporting yourself in this work that's really difficult and can be emotionally exhausting. Feel free to kind of drop in the chat. But for us, I think it's so important to keep track and tabs on how we're feeling, since it has such an impact on outcomes. It has such an impact on perspective. And so just kind of practical strategies, seeking supervision, utilizing, substance use counselors, working with a therapist to address trauma and pain. I think often I've worked with a lot of staff that I've supervised where maybe their unaddressed challenges were coming out because they were triggered by work with an individual. In the chat, I see taking mental health days once a month. I'm a huge proponent of mental health days. We have sick days for a reason. Taking time away, use prayer as debriefing, spiritual work, time with family, dogs. I love my dogs. I'm 100%. My dogs are my self-care. 100%. So engaging in meaningful case discussions. So I think the other thing is really talking through processing and debriefing with the team, right? So using supervision to talk through meaningful discussions, because so often we get stuck in the day-to-day work where it feels hopeless, it feels redundant, it feels like we're doing the same things over and over. And so being able to step back and look at things from a 20,000 foot perspective and think through why people are doing things the way they're doing. Often when we start to feel like we're stuck or we're banging our head against the wall, sometimes it's stepping back and reevaluating our approach. And often it's maybe our approach is we're driving our own agenda, and we're driving our own agenda because maybe some of these external pressures, or maybe because we're burnt out and we're tired and we just want this person to be better, right? We just want them to feel better. We want them to have housing. We want all the things they want that, are the barriers are creating barriers to get to. So for sake of time, I'm going to move to the next slide. And these are just, I won't spend a whole lot of time on this because I see that we did a full training on empathy fatigue. Oh, awesome. Yeah, so reference the empathy fatigue training because I think it's so important in this work. So we're not going to spend too much time on it, but I think all of the strategies that were dropped in the chat, I think are great strategies. And I used to be a person who hated the word self-care. And I think it was because the reason I hated it was because I felt like it was very trite, and it was like they would throw self-care or yoga or pizza at us, but really like self-care, the things that were perpetuating burnout were systematic. They were all these issues. They were system level barriers that, me taking yoga isn't going to cure it overnight. And so I think that's why it's so important to engage in some of that supervision and some of the system level work. But since you guys had a whole training on it, I'm going to move past this really quickly and just talk a little bit about, so next slide. So the one thing I did want to spend a little bit of time on is kind of the difference between burnout and compassion fatigue. And I know colloquially they're really used interchangeably. And so compassion fatigue is a state experienced by those helping others in distress. It's a cumulative physical, emotional, and psychological effect. The cumulative physical, emotional, and psychological effects of continual exposure to traumatic stories and events when in the helping capacity. And so, we hear about burnout from everyone, right? Bankers can burn out, lawyers can burn out, but what makes burnout different from compassion fatigue is really it's about burnout plus secondary trauma. And so it's unique to the helping role because it's burnout plus we're carrying vicarious trauma, or we're carrying other people's experiences with us. We're carrying all these stories and walking alongside with individuals. And so it's very unique to the helping role and the helping capacity. And so making sure that we're taking intentional efforts to fight compassion fatigue, because it's so hard once we're at that point where we're at the apex of compassion fatigue. It's so hard to take that step back and try to get everything back in the box. And so that's why kind of self-care plans and specific strategies to ensure you're taking care of yourself so that we can best support the individuals we're working with. So next slide is just a little bit about kind of a mental health self-care wheel. So some of the strategies that you all dropped into the chat are definitely a component of this, but you think about the different domains of wellness as it relates to individuals that we're working with. You want to make sure you're addressing all the domains of wellness for your own self-care. So physical, professional, psychological, emotional, spiritual, personal, and then physiological too. So the last piece, next slide, on self-care is just, so there's creating levels of self-care too. So there's kind of the protective levels, which are really daily, weekly strategies that you're taking to make sure that you're taking care of yourself. And as somebody dropped in the chat, those monthly mental health days are kind of those protective factors. And then maintenance, you think about how are you maintaining self-care? So it describes the activities that restore your hope and remind you there's beauty in the world. And you think of maintenance like a car. You take the car in to get oil change. That's kind of the routine maintenance to clear out the pipes. And so for me, when I was doing a lot of the direct work, it was at least once a month, I would just like go hike. I needed to be in wilderness. I needed to be near, something beautiful. So you have kind of those preventative measures that you're taking to make sure you're preventing burnout and compassion fatigue. And then throughout the course or every month, every couple weeks, you're maintaining. And then contingency is kind of a plan that's specific for like, okay, I'm getting to the top of the hill. I'm seeing signs of vicarious trauma, and I need to make sure that I have a plan in place to address these. And so often, with my outreach staff, we created levels of self-care plan. Here are the protective factors I'm going to do. Here are my maintenance, and here's my contingency plan for when it's getting close. And for me, from a supervisory role, I did it with my staff, because they identified signs that were like, this is signs that I'm starting to burn out. And so I was able to see them. And so to Scott's point, I believe the slides are going to be shared. We can also send out, I have kind of a document where you can do this with your staff. And so we can also make sure that's attached to where it's just like in a preventative maintenance and contingency plans for self-care.
And one other thing I wanted to add that I think we like don't do well as a profession is that we should like normalize that this is something that we might all experience. I think there's a tendency for us to feel like it's for whatever reason, I don't know how we got here, but that feel like it's an unusual experience, but it's a very common experience. I think especially with, like I worked in one of the largest encampments in Boston, and doing encampment work and working with people who are losing them frequently to overdose. Like, it is not surprising and shouldn't, we're here talking about harm reduction and reducing stigma, and yet we have this like stigma within our own profession about burning out. And when it in fact, it's almost like it would be expected for this to happen. So trying to create on your team, especially if you're in your leadership, like that culture of kind of like no shame, like if you need help, if you need to ask for time, if you need to do an extra check-in to debrief, like that's something that should be welcomed. We should be able to talk about this, because I have to, personally, I've seen too many colleagues kind of like fall on their face and have a really, really tough time because they didn't feel like they could go to like their supervisor or take a break from the field or whatever they may have needed in the time. So I always like to say that because I want to encourage everyone to be open about this, because I feel like that's how we're going to heal, because it's like a collective experience.
Yeah, no, and I think that's such a great point, because the reason I hated self-care and I felt like it was trite is like we have these small strategies for such a systemic issue. And it's really, in other trainings we've done, we've talked about like the different levels of self-care, and there's organizational self-care. So it's really like at a supervisory level, at our leadership level, making sure that, those mental health days are honored. And that was something when I was, a director, I was like, you just got to give me like the day before you're going to be out, let me know so I can plan for it. And so I had staff that would come in at midnight and say, I need my self-care day tomorrow. And I'm like, cool, we'll figure it out. And so I think making sure that's part of the process, right? It's so important that it's destigmatized, because the reality is when we get burnout and when we get that compassion fatigue, we start to desensitize. We start to I became curt, I became short, and I was like, oh, this is a sign that I need to take a step back for a minute. So Megan put in the chat, I was told a while ago that the life expectancy for outreach workers is 2 years before they get burnout. I have heard that too. I can tell you with my outreach staff, I had outreach staff that worked for 6 years for me. And I think the reason was because we made sure that self-care and actual sustainability of self-care practices was part of that agency. So I think, it's so important to destigmatize some of this. And the reality is it's going to impact us all. And so making sure it's part of that conversation. So
yeah, the work is hard. The work is so emotionally hard, and you're here because you care about people, and that makes it harder. So yeah, I think couldn't agree more that those are such important practices.
So I think our next slide is just some resources that we have. And again, the slides will be, sorry, just kidding. It's a poll. So they dropped a poll into the chat. We shared some resources that Teresa referenced earlier, and we'll share the slides out that have just resources if you want more information on harm reduction. It sounds like there's some really great harm reduction practices already happening. And then we just wanted to leave a little bit of time for any questions, any scenarios or situations. Teresa and I are going to stay on. We're happy to answer any questions.
And also, if there's any like particular examples that you want a harm reduction strategy for, I will be the first one to say that I cannot fit all of the harm reduction strategies into one presentation. I could probably do like 6 hours of this, also because I love talking about it. But if you have someone you're thinking about, if you want some support around that, now is a good time for that as well. We have a little time at the end.
Well, we will stay on, but we thank you all for kind of your participation today, for your willingness to share. We know implicit biases and harm reduction is often a very heavy topic. And so that's why we definitely wanted to end with some self-care and just talking about the role of the providers. So we will stay on, but we thank you all for your participation, and we're here for any questions.
And encourage you to check out these resources. We didn't go over all of them, but also the poll if you have time, so we know what future topics you might want to learn about or that we didn't get to cover today. But thank you, everyone. I think it was great discussion in the breakout groups, great participation. I appreciate everyone being here.
Thank you.